much. Thank you for inviting me. Thank you, Mott. Thank you, Mara. Thank you, all of you. And my wife is especially thankful for just to have me at home this weekend, and you are. I have a very difficult task, I think. One is to pitch the talk rightly, because there is very different skill sets in the room. The other one is to talk to you about how to get to sleep while I'm going to keep you awake after having had lunch and all of you wishing to go home. So I'll try to do my best. Let's hope that I'm successful. So that's what we want to do. We want to go from non-sleeping to sleeping. But please not during the lecture. Wait a little bit. So, as many of the speakers have done, I will talk to you a little bit about what is the healthy sleep, then we'll talk about what are the sleeping problems that you can find, or what we can find, and then finally a little bit about the management. So what is healthy sleep? There's different things or different parameters that measure sleep. One is the length of sleep, the duration of the sleep. So as you can see, and as you all probably know, it changes during the life of a person. And as you can see, the recommended sleeping hours from a baby is about 17, and from an old age pensioner, it gets to 7 hours. So there is a difference of 10 hours of sleep from one end to the other of life. I'm not going to recite them all, but you can see what are the recommendations for every age group. Then there is the sleep continuity, which is how well we sleep during the hours that we sleep. So it's something that is called latency. That is how long it takes for you to fall asleep, and usually should be less than 15 minutes. If it's more than 45, then we have difficulties. There is the awakenings. We look at awakenings longer than 5 minutes, because shorter than 5 minutes it can happen. It happens usually when we are in REM sleep, and before we go into another phase of sleep. We'll see now. 0 to 1 awakenings is fine. 4 or more is a measure of poor sleep quality. Wake after the sleep onset is how many minutes are you awake after you've started to sleep. So if you have awakenings, how many in total they are. So less than 20 minutes is fine, more than 50 minutes is problematic. As you can see, there is a difference between what is recommended or what is thought to be good and what is thought to be bad. And this, because in these spaces that are in the picture that I'm putting are dotted white with black dots, is because some people is a bit longer, some people is a bit shorter. And then the sleep efficiency. The sleep efficiency is what percentage of time you are asleep during the hours that you are in bed. 85% or more is good. Less than 75% or less than 74% is not as good. Sleep architecture, I don't want to talk too much about it. There is different phases. There is the N1, which is light asleep, and this at the beginning it lasts for about 1 to 5 minutes, and it starts, alpha waves start disappearing, and we start having the slower waves. N2 is when our heart rate and our temperature drops, and they start appearing more slow complexes. N3 now, N3, N4 before, is when we have the spindles and the K waves and the delta waves, and is when we are more asleep. Then there is the REM sleep, which is the rapid eye movement, which is when we dream. There is no muscle tone apart from the eyes, and we dream vividly. And as you can see, these phases vary. So we have more deep sleep at the beginning of the night, it goes decreasing, it decreases, and then we have more REM sleep as the night progresses. So we go from, it's usually about 5 periods of REM sleep that last 10 minutes to an hour. Naps, during the day naps, so good and so popular in Spain. We shouldn't, actually. There is controversy. Very recently I've read that actually we are not monosomnics, if not that we have a period that we should sleep during the day. But nevertheless, what is recommended by the American Sleep Association is that we should have very few, so every 24 hours we should have 1 or none. More than 3 is very problematic. The duration should be less than 20-30 minutes, so a small siesta, and more than 100, that's a mistake, more than 100 minutes is unhealthy. And the frequency should be 0 or 2 per week, so far less than we would like. So that's how normal sleep should be. Yeah? When these things, when we don't have this, when we don't fulfill this criteria, when we don't sleep in this way, then we have what's called sleep difficulties, or what we call here sleep difficulties. These have got different names in different classification systems. So, in patients with 22q11 deletion syndrome are common, and there is many risk factors for that. As you know, they have problems with the airways, they have tracheomalacia, laryngomalacia, subglottic stenosis, which difficulties the entry of air. They have difficulty with the palate, pharyngeal insufficiency, and postoperative complications. The oropharynx and midface hypoplasia and microapnea doesn't help. Sometimes these patients have aspiration, which also is a problem at the time of sleeping. The heart failure, the congenital heart defects, reflux, dysphagia, constipation, all of these don't help. Hypotonia, which Nuria was just mentioning, cervical spine abnormalities, which is related to central sleep apneas, seizures and epilepsy, which wake us up also during the night, and also the psychiatric complications, which, you know, many as we've been hearing all these 2 days. The thyroid disorder and the hypoparathyroidism are complex, and hypoparathyroidism can be related or confused mainly with leg cramps during the night, and the immunologic, which is frequent infections. You can have temperature, shivers, and also wake you up. Yeah, so there's lots of risk factors for why people with 22q11 deletion syndrome will have more difficulties at the time of sleeping. These difficulties come and go, but mainly are maintained. And there is no very good research actually about it, but everybody agrees that that is the case, all the articles that I've been able to read. So, sleep disorders, there are many, and you can find them in the ICD-11 webpage and in the DSM-5. The insomnia disorders is when one experiences that has poor quality of sleep, and it can be because it takes you long to go to sleep, because you wake up in the middle of the night, or because you wake up early in the morning and you cannot fall asleep again. There's short-term insomnia, which worries but not that much, and there is the chronic insomnia, which is far more worrying. Hypersomnolent disorders, I'm not going to say much about it. Both of short-term insomnia and chronic insomnia are increased in prevalence in people with 22q11. The sleep-related breathing disorders, both the obstructive sleep apnea because of the difficulties with the airways entry, and the central sleep apnea because of the neurological difficulties, are also more common in people with 22q11 disorders, and also, as I said, the sleep-related leg cramps. That is sort of, let's say, directly because of the physical problems. Then there is all kinds of disorders because they are associated to mental health difficulties, neurological difficulties, etc. As you can see, there is lots of circadian rhythm sleep disorders. This is that what we should have is 8 hours of sleep or 7 hours of sleep, and to 17, and during the night and not during the day, it keeps shifting, keeps moving, and we need to sort of correct it and bring it back to what it should be, because, you know, it's very difficult for us to sleep during the day and be awake during the night. With all this internet and the youngsters can contact all over the world, it's far more difficult. But I only have to refer you in, you know, when I was studying medicine, I used to work in a hotel, and I do remember that of the night porters that used to work from sort of 10, 11 o'clock at night till 8, 9, 11 o'clock in the morning the following day. They always looked tired. They were very young, very irritable, and it was very difficult to get a smile from them. I saw them in summer, then I saw them in winter, in Mallorca, and in winter they were different persons. So, and that was due to not sleeping at night and sleeping during the day. There's also the sleep-related movement disorders. The restless leg syndrome, I assume many of you have heard about it, periodic movements, etc. So, bruxism is also quite common. but there's many of them and they need to be evaluated. With regards to parasomnias, there is difficulties during the REM sleep, so which can be the hypnagogic difficulties or hypnagogic hallucinations. This is when you fall asleep that you sort of wake up. It's one of them that has got a fantastic name that I want to share with you, that is the exploding head syndrome, which is sort of, you have the sensation because you hear a very loud noise that your head is exploding and you wake up, and then it's difficult to fall asleep again. And there is, you know, due to medical, to drugs that we use for medical reasons, or to drugs of abuse. During the REM sleep, we can have the recurrent sleep paralysis, nightmares, and the difference between the REM sleep and the non-REM sleep disorders is that during the REM sleep you wake up and you are sort of fresh, and during the non-REM you wake up and you are sort of dizzy. If you wake up, it could well be that you are still awake and that you move around and or go and have food, go out of the house if you have a sleep waking. So in the non-REM sleep you don't fully wake up, or if you wake up you are very confused. In the REM sleep it's very easy to wake up and you remember what had happened, and then there is all the other related to drugs that we could take. I know it's difficult, but there's another way. So what happens if you go to sleep? Is that important or not? Well, it is actually, apart from feeling tired and you know how you feel one day that you haven't had much sleep. They can cause motor vehicle collisions, the attention at the school will be poor. Also, we are very much likely to respond to stressful situations, so we get stressed and anxious far more easily. We can develop all sorts of somatic problems. It's been evaluated, and people that have difficulty sleeping feel that their quality of life is not as good as when you don't have a sleep difficulty. It can, as a consequence, can have emotional distress, mood disorders, and all sorts of psychiatric problems. Our cognition, our memory, all the sort of the intellectual abilities that we shall be talking about are also affected, and we are not functioning as we should. And then we can see that people can have behavioral problems because of no sleep. I remember a patient that I had who had a Phelan-McDermid, not a 22q11 disorder, that went to Portaventura, which is a theme park here in Spain. And when they went there, he had very rough trip. It was there was lots of waves, and everybody got sick in the ship. And on coming back, the mother, to avoid it, gave him a medication for the seasickness. And we don't know why. These kids are usually very sensitive to medication. We don't know why. Couldn't sleep well, and they started showing some very bizarre behaviors. Was admitted to hospital. And I was on holidays when I came back on a Friday. He was just about to have an IV fluids put with sodium valproate because they thought it was thought that it was a status epilepticus. I knew the complications that we were going to have in our unit because our nurses are not, you know, so well skilled in managing drips and intravenous infusions. And I asked the neurologist if it would be okay to start on Monday, and I will try to make him sleep on that weekend. And I used one of the medications that we're going to talk about. I slept for about 24 hours, and he went home on Tuesday with no other symptomatology. So it can mimic any psychiatric disorder, or it can precipitate any psychiatric disorder. In the long term, we will have hypertension, dyslipidemia, cardiovascular problems, weight-related issues. People that doesn't sleep well is usually overweight, can develop metabolic syndrome. The risk of developing certain cancers is also increased. It worsens gastrointestinal difficulties, can have erectile dysfunction, and of course a cognitive decline resembling dementia. When does somebody who doesn't sleep well needs to see a doctor? Well, in a way it has to impair you somehow, but if you are not getting enough sleep, or if your relatives don't get enough sleep, if they do get enough sleep but they don't feel refreshed, they feel tired the following morning, if they keep falling asleep while driving in the middle of a conversation, if when they laugh or have a very strong emotion they collapse, if they reenact dreams, so if they enact dreams, so if they, when they are asleep, they sort of move around, get up, go to places, if they snore a lot, if they sleep talk, if they sleepwalk, if they move around a lot when they are in bed, if in the morning you find that there is unexplained damage in the house, that food has disappeared, it's probably because somebody is waking up in the middle of the night and moving and going and eating. When the sleep pattern changes after starting or changing medication, it also should be commented with your GP or with a doctor. Well, up to here, the sleep difficulties, and now I would like to talk to you about the management of sleep difficulties. Let me tell you before we start that the most important bit is the simplest bit, and is what we have very many difficulties to do, but there is no other way. We have to do it. So, first of all, how we do evaluate it. Well, it's very important to take a very good sleep history. You can find it on the internet. If not, I got a pro forma that I use, like a memo aid. But you have to have the story ideally from the sufferer, from the patient, and from a bed partner, or somebody that lives close by and can tell us what happens when the other person is asleep. You need to look at the behavior during the sleep, and also the behavior during the day when they are awake and they sort of function normally. You have to look at the sleep hygiene, what happens before they go to bed, which is the important bit that I was telling you about, and which we'll see in a minute. And you need to have a good timing of events. You need to know when it happens, how it happens, how long it lasts, etc. You need a good physical examination. Very important to have a body mass index, weight, heart rate, pressure, blood pressure, etc. And also a visual examination and physical examination of the head, neck, and facial morphology. Here on the right, you can see how the airway can be, that are all normal, and you can see how more open or closed it can be. In the further right, it's very difficult to get air through the mouth, and in the picture on the left is far more easy. There is very good questionnaires, the Epworth Sleep Scale and the Pediatric Sleep Questionnaire. I would recommend, but use them judiciously. And first, it doesn't substitute the taking of a very good sleeping history. And then we need to formulate, and we need to find characteristics that predispose. In this case, would be tracheomalacia or problems with the palate. Activities that precipitate, that could be having a coffee at 7 o'clock in the evening. And attitudes that perpetuate. If a person is anxious, then they will get more anxious about not falling asleep. They will start thinking about it, and that in return will complicate all the process of falling asleep. If after that we install treatment or not, and in some cases directly, we need to further investigate, then it has to be done by a sleep study, or polysomnography, which there is usually centers in hospitals that do that. They put you full of cables. Have you ever seen anybody have that? Full of cables everywhere, in a room, people observing you, taking notes, and they say, now you need to sleep. It's not easy. Hopefully, pretty soon we'll be able to take it home and go on the following morning. For some things you can do it, to control the apneas and the time that you spend breathing or not at night, you can do it from home with a portable recorder. Bronchometry is multi-professional, usually involves neurology, usually involves pneumology, nursing, and is used for difficult cases, cases that we cannot diagnose or that we cannot help, usually for the sleep-related breathing disorders, and is a good way of detecting if it's a central apnea or if it's obstructive apnea. Also for some sleep-related movement disorders, and for some of the parasomnias, which are difficult to differentiate. Also with epilepsy, so there is also an EEG recording, and you can know if it's a nocturnal frontal lobe epilepsy or if it's a parasomnia. So that is the first technique, tool that we have to use. We have to use it always. There is no way around it. We have to have a good sleep hygiene. It could well be that it doesn't work, and that we will need to do some other stuff, but we cannot stop having a good sleep hygiene. So if you come to the clinic and let's say somebody asks you to have good sleep hygiene, they give you all the advice, you go home, do it, it doesn't work, you come back to clinic, we put you on medication, and then you start drinking coffee at 7 o'clock or 8 o'clock in the evening, it's not going to help. Yeah? So the sleep hygiene is fundamental, it has to be there, and I think it's the most important link of this conversation, of this talk. So sleep hygiene is behaviors that are related to promote the sleep and to have very good sleep habits. Yeah? And the rest I think I've already told you. So it's necessary and could not be enough, but we cannot stop it. So it's not that we do good sleep hygiene, it doesn't work, so we need medication, and we stop the sleep hygiene and we go on the medication. No, we have to carry on with maintaining the sleep hygiene. So what sort of things are involved in the sleep hygiene? One of the important ones is the sleep environment. You need to have very good setting to go to sleep. It cannot be exciting, it has to be relaxing, dull colors. Need to be careful where you put your bed, so don't put your bed facing the window, because if there is a full moon, you could be distracted by what is going on outside. Try to avoid having electronic devices. One thing that is repeated, and I would say again, is the bed is for sleeping, or the bedroom is for sleeping. Don't use it for other things. Don't use it to watch TV. Don't use it to watch your favorite series on your iPad. Have to be quiet. If you cannot stop having sounds, then there is earplugs, there is white noise machines that seem to be working very well, which the one at the top right is an example. It has to be dark. If people is waking up in the middle of the night because they have a dim light so that you don't fall over. The temperature has to be comfortable, better if it's cool, and you have to use a blanket, but not being very hot and sweating cold during the night. Safe, so if somebody has sleepwalking or some other problems, cannot be falling over objects in the middle of the bedroom. And the bed is only for sleep and sex, so don't take your bills and review them when you are in bed, please. A sleep position is very important, especially for people who has physical disabilities, difficulties with mobility. They can have ulcers, they can have all sorts of trouble, so have to be very careful. And the recommended ways is on the back or on the side. The sleeping on the back is very good for back pain, but on the side is better if you have sleep apneas or snoring, or if you even have reflux. So probably better sleep on the side. The bedding is also very important. You have to look at everything. Mattresses, they have to be soft enough so that you don't feel uncomfortable, but hard enough that you don't sort of get sucked by the mattress. Pillows, if you have, especially if you have problem with sweating a lot, or you don't sweat, need to be the right consistency, and varies from person to person. You have to find your own one. And the blankets, they're very important also in children or in adults with sensory integration difficulties. There is weighted blankets. All of these pictures I took them from the web, and they sell them in Amazon. So they are easily available. There is quite a lot of information that you can pick up very easily also, and it gives you tricks and how to organize your bedroom. And then the sleep schedule and the practices. In children with 22 and in adults with 22 to 11, the need for sleep could be increased. So you need to allow for a longer sleep that I've told you, and also you need to allow for naps during the day. You need to get into sleep and waking routine, and you don't need to shift it. Not because you are on holidays, you are going to change it all. So it needs, the recommendation is that it shouldn't change from more than an hour a day. So if you go to bed usually at 8 o'clock then, or at 9 o'clock, then don't go further than 10 o'clock. Engage in relaxing routines. You have to, it's good to have a warm bath before going to bed, warm drink, not caffeinated. You can do meditation, you can do deep breathing. Avoid exciting activities before bedtime. During the day, avoid naps, exercise, and the more you exercise, the better. Don't do it 4 hours before going to bed because you can still be a little hyped if you do it. Implement routines and structure. I think in German it's called Zeitgebers, which means that you sort of have your day structured and you know what's coming all the time. If you have a bad night, the following day continue with your normal activities. Don't go to bed and sleep because then you'll have the following night also disturbed. Avoid coffee, avoid stimulants, at least 6 to 8 hours before you go to bed. Avoid large meals and alcohol before going to bed. Decrease the fluid intake so that will decrease the need for you to go to the loo and less wake-walk gaps. The older you are, the more important it is, I'm realizing. Don't go hungry or thirsty. To have a light carbohydrate-rich meal is good, and it helps you to settle down. If you are not sleepy, don't go to bed, because it's worse to stay in bed awake and moving around. And use common sense. So all the two pictures on the right, this one is not relaxing, the other one is. So, you know, one bath, if you have your friends and toys in the bathroom, is not going to relax the child. So for all of that, use common sense. And also very important for the caregivers. You know, parents that don't sleep well, they have difficulties, and you will be woken up during the night because the child doesn't sleep. You have to take car rides, prepare meals, etc. to help them to sleep. And I think yesterday the person that talked about their experience, they said that they were not sleeping well at night because they were worried that something will happen to their children, which is very important. Or you have to keep taking the child to their bed if they have sleepwalking, or if they come to your bed. Sleep-deprived parents are usually helpless, they are frustrated, they are anxious, they are angry, they'll say blame, and they're very negative about life. And we know for many disorders, and parents that are not well, this sort of translates to the kid, and then you have a vicious circle creating that kid is not sleeping, parents are not well, because parents are not well, kid is not well, so it goes round and round. So it's very important that you take care of yourself too. Non-pharmacological interventions. Relaxation training, probably you need some help with that. Relaxation training for progressive muscle relaxation, breathing exercises, mindfulness, meditation techniques, guided imagery, stimulus control, which is need to limit what we've been talking in sleep hygiene, limit the activities, some activities that you do, sort of get a schedule, and so that your body gets into the swing of things and knows when bedtime is coming. There's little restriction is also, you know, having very well organized how you do it, and if you have the sleep-wake cycles, displacements, then sometimes you can push people sleeping less and less every night until you lose a complete cycle of sleep, and then you start again on the following cycle. And cognitive behavioral therapy, which is, let's say, somehow a sleep hygiene with cognitive aspects that talk about being more positive and abandoning the unhealthy beliefs like I'm not going to sleep tonight I'm going to be in bed, I'm not able to sleep, etc., etc. Pharmacological interventions only after these other two have failed, and they are determined on a case-by-case basis. And you have to look at the cause of sleep, the child medical history, what other comorbid disorders there are, available efficacy data, drug interactions, etc., etc. Over-the-counter drugs, which is a drug you can go and buy and don't need a prescription. There is iron supplementation. Use it if the the person who has the lip problems has iron deficiency, and you aim at the 30-50 nanograms per liter level. Antihistamine drugs, I wouldn't recommend them. They have quite a lot of side effects, but nevertheless, consult with your GP or your doctor to see if it will be good for you. Then there is natural remedies, you all know, uncertain efficacy, and you need to be careful with all the interactions. Melatonin seems to be very good. There is lots of research that is coming up, and it gives a better, it helps to synchronize the circadian rhythm, it improves the onset of the sleep, and increases the duration of the sleep. It doesn't seem to increase the percentage of good sleep that one has, but I find difficult to understand, seeing that it increases the sleep duration and it makes you fall asleep quicker. It's useful in insomnia, as related disorders, and many of the sleep disorders. It does have some side effects, headache, dizziness, nausea, and drowsiness, but usually are very irrelevant. There's immediate release, that is, you have difficulties falling asleep, and there is controlled release, that if you wake up in the middle of the night. So don't try to treat the waking up in the middle of the night with something that works for 3 hours. So you need to use another kind of melatonin. And then the prescription drugs. We'll out of this, which I don't advise you to use. And then what I wanted to talk to you just at the last minute is about real psychiatric clinics. I think what we need to do, when people come to see us, they usually don't come only because they have a sleep disorder. They come because they have a sleep disorder and many other problems. So what we need to do, I think, is, or what I try to do, at least in clinic, is to optimize the treatments that they are on, and sometimes, change medications, and so that we can have better management of sleep. It's very rare that doing that you don't control the sleeping problems. I don't think I've ever referred anybody, apart from central sleep apneas, to a sleep clinic. So my advice: if you have a child that is overweight or is very hungry, then use quetiapine. And it's possible the slow release one, or taken at night. If you have a child that is overweight or that has a lot of hunger, then, overweight, or is, if you have a child that is thin or is difficult to feed, then you risperidone and olanzapine that increase the appetite. And also if they are using this medication for other things. If you use aripiprazole, monitor it carefully, because aripiprazole sometimes helps us sleep, sometimes doesn't, and interferes. So, but we don't know beforehand which one is which. Mirtazapine and trazodone are also good drugs. If somebody is depressed, if somebody is anxious, and they help a lot at the time of sleeping, even with low doses. And if a child has ADHD and needs to be treated, then atomoxetine also increases sleepiness and is very useful to help sleeping problems. And with that, the only final recommendation I have is use common sense and start low and go very slow. Thank you.